My name is Dr. Justin Ernat. I'm an orthopedic sports medicine surgeon at the University of Utah Health. Today we're going to be presenting arthroscopic posterior cruciate ligament reconstruction using Tibialis Anterior Allograft with pro-cinch suspensory fixation on the femur and a biostion biocomposite interference screw on the tibia. So as I'm making the medial portal, one thing that you can consider when working on your PCL is making it just a little bit higher than you normally would. That'll allow your instruments to get through the notch and down over the back of the tibia to really get to your PCL stump. Now as I venture into the posterior aspect of the knee, I got to be cognizant of where my posterior medial meniscal root is. One of the most commonly reported things during this procedure is iatrogenic root injury. And so there's my posterior root there. So I got to just constantly checking as I kind of debride some of this PCL tissue on where that's at so that I, number one, don't hurt it, but number two, I need to drift slightly lateral from that in order to anatomically reconstruct this. So I'm just going to kind of make a mental note from this lateral viewing portal of where those two bundles are. And you can see how much bigger the bundle is here. And so our tunnel is going to come right up into this corner with just a little bit of overlap into our posterior medial bundle. But I have my 12 o'clock, my 9 o'clock, so we're going to put that right at around 10 o'clock. We'll make a posterior medial portal because it can help with tibial preparation, help with viewing. It can also help with suture management and graft passage. We can use a percutaneous access kit, kind of like you would do with shoulder or hip arthroscopy, to kind of help us safely get down there and maintain the same trajectory. Thank you. It'll allow us to effectively, efficiently get down to the back of the knee without having to retrace our steps on trajectory with each new introduced instrument. A cannula can be helpful back here. That way your axis is achieved. So again, I'm just carefully introducing the threads here. I like a threaded one. Smooth one works. We just want it to stay put. And you can see by the time we've introduced the cannula, if we had come in more shallow on the femur, we would be hitting the femur. Our cannula is in place. We can see our residual stump right there. We can see how close the meniscal root is. It's a great view. They literally lie on top of each other. I typically like to debride all of this off and just peel that capsule off the edge of the tibia. But as I tent it, you can see the striations of the capsule back there. And I just want to release just enough where I either completely fall off or I even start to see a little bit of muscle fibers from the gastroc muscle bellies. You can see the red flush of the gastroc muscles back there. But when I'm looking for a landmark, there's my horn of the medial meniscus. I follow straight back behind that. And that's where I put my tunnel. But we got a decent view here. We've already looked at our landmarks from before. And I can hook all the way back on that tibia through my little capsular opening. And if I pull on it, you can see the tibia move, so I know I'm hooked. I usually go somewhere between 50 and 60. I am just yanking down on this guide to keep that hook. It's kind of like a fishing hook back there. The nice thing about this guide is it ratchets in place, so I can even just leave it be. And if you're short-handed, that'll hold while I hold my camera and drill. I check the fluoro once I have my guide in place. I like to make sure that that edge that I'm falling off is indeed the edge of the posterior tibial footprint. So I'm going to bring in my threaded pin. Like we said, that guide should protect us. But I'm just going to bounce it up. You can see the bubbles coming out. So I'm there. Okay, we can see it. So at this point is where I would check a fluoroscopy shot for two reasons. Number one, I like to check my pin trajectory. Number two, the back of the tibia is concave. And I want to make sure the trajectory of my pin, which I set at 60 degrees, has a acute enough angle so that when my bigger reamers that we use in PCL reconstruction, like a 10, 10.5, 11, does not fracture or blow out the concavity of the back of the tibia. We've already sized our graft at a size 10. I like to drill a half size higher. So we're going to drill a 10.5. That just helps with the graft passage a little bit. So we got our reamer in place. I'm protecting my capsule. You can see how that pin tried to jump on me, but because I had my PCL curette, I protected it from going into the popliteal artery. We're just going to take a peek actually through our posterior portal as well, and you can see my tunnel back there. Now we just got to drill our femur and pass our graft. I always start out at about 60, but I'll actually go as low as 50 or 45 if I need to get that acute trajectory. So we'll come in through our anterior medial portal, and this has got our measurements. We have our 10 graft, and so we're going to get this centered where we want it and lever in. So we're looking at a 10 graft. I want a 5 offset radius. So I got my 4 there, and then the 6 is flush with the cartilage. So that looks like a great view. I like to drill a pilot pinhole. I think that it helps me. I can adjust if needed without taking away too much bone. But also that when I am ready to ream with the outside in reamer, the reamer will find the path of least resistance and follow that pin track. So we're going to switch that. I'm going to remove the inner collet of my drill guide. And now we're going to come in with our retro cutting device. We're going to come in on forward. It should. You can see it fell right into our same hole. And now that I'm bottomed out on there, I'm going to pop this out. I'm going to hold my top hat and finish off into the joint. There it is. There's my black line. That's where it's going to start cutting. I don't want to start that black line on bone. I could risk fracturing the bone. So I'm going to get it a little bit off the bone. I'm going to slide my rubber marker down onto the top hat so I know how much I'm reaming. And then once I'm ready to go, I'm going to ream back on reverse, and that's going to cut. And I'm going to ream back to about 20 millimeters or so. Okay, and it should bottom out on our top hat, which it is right now. I can feel it. And I'm going to ream back in and out. It's going to clear some of that bone from our tunnel. And then I'm just going to switch back to a forward ream. So our tunnel is exactly right up against the articular margin. It's right in that anterolateral footprint. And we're going to use a separate passing stitch for both our femur and our tibia. So I'm going to keep this one kind of up towards the ceiling just so that it doesn't get wrapped up in our tibial passing stitch. Sometimes it can be hard to see. You can see the black just peeking around. Looks like it's a little bit of a tough angle. And this, it's easy. We're going to pull this up and out. And now we'll just dock it there. And I can still come and get it out the medial. And now it's just waiting from my little extra helper portal back here. We'll pull it out medial, okay? We're going to actually pull our tibial side in first through the medial portal. I have my graft up. I always like to pull all the stitches first. I want to pull the graft on a separate pole. Okay, so our graft is entering into the back. I just felt it pop through. Okay, and I'm going to pull it all the way down until I see the tip of the graft here. Again, we do stitches first. So there's our view of the button. Our button's going to pass through. Our graft is still there. One thing you don't want to do is pull back on the graft and have the graft sink into your tibial tunnel, because then you just negated the point of all your suture management. Our button's on the cortex. We're going to shorten our button. Here comes our graft. Sometimes it's good to have, once your button is on the cortex, have someone pull just a little counter tension on the graft, because that'll keep your button from flying out your skin. But there goes our graft right up into the tunnel. Okay. We pull back on it a little bit, get the slack out, re-cinch, and there it popped in nicely. So I'll cycle my graft through, get any residual creep out. I fix my graft in 90 degrees. With an intact ACL, I like to apply a maximal anterior drawer to kind of take out any looseness out of the graft. I want this to be as tight as possible. Sometimes by simply just pulling in line with the graft, it actually will pull the tibia forward into that anterior drawer. And so I'm going to be pulling on my graft. I got my nitinol wire on the front of the graft. I want to push the graft towards the back of the tibia so that it recreates those posterior fibers of PCL as much as anatomically possible. Once I get my screw going, the other thing I don't want to do is forget about the position of that nitinol wire, because the nitinol wire can be pushed up into the popliteal fossa. So at the very last threads where I can see my screw and when I'm getting some bite, I take the nitinol wire out. I don't want to pierce the popliteal artery with the nitinol wire. Lastly, we do our checks and balances. So the first thing we do is a posterior drawer. We have no posterior translation. And you can see there, just even looking at it, it looks nice and taut. Our check is not to pull this way. That'll give us false hope. We want to see if it pulls off the wall. All right? And you can see as I'm pushing on it, it does not leave the wall. So we know we've got good tension. Our final construct, single bundle, PCL reconstruction, suspensory fixation on the femur, interference fixation on the tibia. It looks nice and anatomic.